the screen now?
Sure.
Happens that they quickly and gently stick to the skin to allow in situ collection, storage, and biochemical assessments of microliter samples that's obtained directly from the skin. So why do we use exocrine glands? Like we have apocrine glands also, right? So now these exocrine gland sweats, they are
You should begin the stream too.
producing the highest volume of sweats, and they are found in every region of the body, whereas the apoexocrine or apocrine glands, even though they are the two major sweat glands, they are relatively complicated and they have a varying chemical composition. So just an overview of how this sweat analysis is collected and how does this take place. So for the sweat analysis, the sweat is collected and it is stored non-invasively, while avoiding contamination and discomfort. And yet the need for specialized equipment and like professionals is not required because it has a limited sweat accessibility. So without the requirement for experienced staff, microfluid patches can provide a real-time and cost-effective analysis in any environment. So these devices, they're designed to detect a particular or so what these so these exocrine glands, the originates in the secretory coils, connecting via the tubular lumen to ducts across the dermis. So the activation of the eccrine glands are cholinergic nerve endings, and these secretory coils will lead to like a calcium influx into the surrounding cells. So this results in the transport of sodium and calcium ions into the lumen, and an elevation in the sodium chloride concentration compared to the interstitial spaces in surrounding cells. This generates an osmotic pressure gradient that forces the water into the lumen. So the diagnostic assessment, according to the concentration of these components, can benefit from the sweat rates. And also like the diagnostic examinations, they like give out exact information on the sweat rates, body temperature, accumulated weight loss volumes, and even like if we have any cardiopulmonary activities. So it's quite interesting if you see, because sweat is something everyone, like we all sweat, and to use that to diagnose diseases is like quite fascinating. So what do you guys think about this?
Thank you, Shilpa, for such a wonderful article, and it is actually really nice reading about diagnostic methods of sweat, like using sweat, and like it's a good thing that we can assess health status with sweat diagnosis. So, does anyone else have any other comments or questions? Okay, so we can move on to the next part of the section, that is the conclusion for today's event. Over to you, Madhuri.
All right. Thank you so much, everyone. Welcome to MedNews Week conference, where our goal is to bring you the most cutting-edge information from medicine's global leaders. I am Madhuri Balasubramanian, and I will be your host today. Before we begin, I want to first acknowledge the great team that helps to make these events a reality. Our founders are two internationally recognized researchers, Drs. Jan Leifman and Chandler Park, who is also the president of Kentucky ASCO. Our chairs include Drs. Park, Leifman, and Pratyusha Ganta. Our associate directors are Muskan Joshi, Gayatri Menon, and myself. Our organizing committee is comprised of Alexandra van der Kijp and Dr. Yavuz Sile. Our managers include Alexander van der Kijp, William Wilkerson, Pallavi Pai, and Ahmed Hashim. Our educational committee includes Sean Jakovic, Shubha Pawar, Harshal Choria, Rabab Abbas, Shrivika Kannan, Sri Harshita, Rita Khan, Isabella Miyawaki, Victoria Maya, Soumya Nadar, Imad, and Helena Colomba. We also want to thank our partners, Vimedi, who are a global leader in medical video educational content, and the National Society of High School Scholars. The moderator for today's event is Rabab Hunaid Abbas. Now, to introduce our speaker, Dr. Michael Pishvaian. He's a globally recognized researcher in translational oncology and precision medicine in the areas of pancreatic cancer and refractory colorectal cancer. He's an active member of organizations like the NIH and the Alliance Pancreatic Cancer Task Force, an internationally renowned physician, researcher, educator who has directed amazing oncology programs in Johns Hopkins, MD Anderson Cancer Center, and more. He has held amazing and multiple leadership positions, including the co-director for clinical research at the Sheikh Ahmed bin Zayed Al Nahyan Center for Pancreatic Cancer Research at the University of Texas, MD Anderson Cancer Center. He is also having the Phase 1 Clinical Program Director at the Department of Hematology and Oncology at the Lombardi Comprehensive Cancer Center in Georgetown. He is the founder of the Tumor Board Tuesdays, which is a case-based weekly discussion on Twitter focusing on interesting biomarker-based therapies. He is also a reviewer and an editor of multiple journals like the GI section in the Frontiers in Oncology. With that, I'm going to introduce Dr. Michael Pishvaian. The floor is now yours, Doctor.
Thank you so much for that far too kind introduction. My name is Mike Pishvaian, as you heard. I'm an associate professor at Johns Hopkins, and it's my pleasure today to talk to you about updates in biomarker-based therapy for pancreatic cancer. These are my disclosures. I'll leave it there for a second. So today I'd like to talk about the evaluation of the frequency of actionable molecular alterations in pancreatic cancer, explore the current data of targeted therapy for biomarker-selected patients with pancreatic cancer, and then introduce some of the new novel targeted therapies that have recently entered clinical trials, which may eventually be relevant for patients with pancreatic cancer as well. Just to set the stage, this is something that I think many of us know, that pancreatic cancer is a very deadly disease. In the United States, there were over 62,000 cases in 2022, and unfortunately, nearly 50,000 patients who succumb to this disease. And this is one of the few cancers that the incidence and the mortality rate are actually increasing in numbers, and it's soon expected to be the second leading cause of cancer-related death in the United States by 2030. Because it's typically diagnosed at a later stage, more than 80% of pancreatic cancers are not curable and they're not operable. And because of that, it has the lowest survival rate of any major cancer. We did make progress, 1% each in the last couple of years, and are now up to a 12% 5-year overall survival rate. In that context, let me talk through a typical patient scenario that'll be the backdrop for this discussion. There's a 58-year-old female with no family history of cancer who presented with pelvic pain that ended up being unrelated, but her workup revealed multiple liver lesions that ended up being pancreatic cancer with diffuse liver metastases. She did have germline molecular testing done at the time of diagnosis, but there were no inherited mutations. Now, before I move forward, I think, unfortunately, many of us are very familiar with exactly this kind of scenario and are familiar with the outcome. We have made progress in pancreatic cancer over the last 10 years, but it's telling that our two current standards of care still remain FOLFIRINOX and gemcitabine nab-paclitaxel, based on studies that were done in 2011 and 2013, respectively. These combinations did significantly improve outcomes for patients, with improvements in 2 to 5 months in overall survival. And more importantly, as somebody who used to see patients who only received single-agent gemcitabine prior to 2011, this has really changed the outlook of pancreatic cancer, because all of a sudden now we have the opportunity to make pancreatic cancer patients feel better, albeit for a relatively short period of time. And ultimately, we know that their cancer will start to become resistant. There is also a standard approved second-line therapy as based on the NAPOLI-1 trial, where the combination of Naliri and 5-FU were proven to be better than 5-FU alone. And when you put these survival times together into a timeline like you see here, we know from historical data that patients who do not get any treatment for their metastatic pancreatic cancer have a survival probably in the range of 2 to 4 months. With current first-line and second-line standard of care, we may improve that survival to about 8 to 11 months with first line and another roughly 6 months with second line. Of course, these are not truly additive, But in studies that have looked at the sequencing of therapy for patients, those who were able to get first-line therapy and stay on to second-line therapy, their survival rates are upwards of about 18 months overall. However, there are consistently about 5 to 10% of patients whose overall survivals far exceed the standard 12 to even up to 18 months, where these patients could live 30 months, 36 months, or even longer in some rare cases. So the question is, who are these 5 to 10% of patients? How can we identify them? Can we expand this group of patients, importantly? And really, to be able to identify and understand the biology of each of these patients is the key. Because if we can actually treat them according to their disease-specific biology, that's when we can really make a major impact. And that's really the underlying promise of personalized or precision medicine, where we can use predictive biomarkers to identify who will benefit from specific therapies. So I like to define precision medicine and actionability. And so these are the definitions that I use. They may vary from person to person, but what I like to define them as is that molecular testing, precision medicine is molecular testing for a therapeutic purpose, in that in any individual patient, there may be distinct targetable molecular abnormalities that are potent predictive markers of response. And these are the so-called actionable biomarkers. And then what do we mean by actionability? Well, in my definition, it's a bit of a gray term, but it means that there's significant activity in patients who have that molecular abnormality in their tumor or that they were born with, but across any cancer type. And that appropriate therapy targeted towards that molecular abnormality leads to what I like to call just disproportionate benefit. What is disproportionate benefit? Well, we'll show you some examples in a second, but really it's about the degree of outcomes, progression-free survival, response rate, overall survival, that is far different than this typical run for a patient with that kind of cancer. Just a quick digression to say that molecular testing for therapeutic purpose is not exactly the same as classic molecular classification. Molecular classification or molecular subtyping really is large-scale molecular characterization, often from large consortia of patient samples using gene sequencing and transcriptomics, things like the International Cancer Gene Consortium and TCGA, where the goal is really to define specific molecular subtypes. These are often pathway-driven and are designed to look at different prognostic groups of patients, although they could also have some predictive relevance. These molecular classification schemes have certainly been studied in pancreatic cancer, and really at this, to sum up really a decade worth of work, there are two core subtypes of molecular classification for pancreatic cancer: the squamous or basal cell-like, and then the classical pancreatic cancer subtype. And the classical subtype are often defined by GATA6 expression. This molecular profiling efforts are also, as I said before, pathway-based, so the efforts will reveal specific molecular pathways that are activated or relevant in that subtype based on the genetic alterations and transcriptomics that are seen. And you can see a number of pathways that have been delineated, starting from all the way back in 2008 with the original publication in Science, till multiple other efforts that have really defined specific pathways. And when you define pathways, then you start to be able to define different targetable subgroups, because if you have a DDR pathway that's defective, then maybe you can identify therapies specific to DDR alterations. Or if you have FGFR alterations that are defective, that are running the cancer cell, then you may be able to target with an FGFR inhibitor. And in pancreatic cancer, we definitely see that next generation sequencing efforts have consistently revealed that at least 25% of pancreatic cancers have these potentially actionable molecular biomarkers. When you break it down, and this is a breakdown from our Know Your Tumor effort from a few years ago, when you break it down, the majority of the actionable biomarkers in pancreatic cancer fall into the DNA damage response and repair category, or DDR mutations, and we know these patients can benefit from platinum-based therapy. Then there's a whole bunch of small but reproducible subgroups of patients for pancreatic cancer, those with alterations in microsatellite instability, different receptor tyrosine kinases, different molecular signaling pathways that are altered, and these are potentially targetable, especially as our drugs to target those pathways is increasing in numbers. So what do I mean by disproportionate benefit? Well, as we talked about, the median survival for patients with pancreatic cancer is about 12 to 15 months, maybe a little bit more, maybe a little bit less. And the second line setting is about 6 months. But about 1% or slightly less than 1% of pancreatic cancers, just like many other cancer subtypes, are MSI high or have mismatch repair deficiency. And when these tumors are appropriately targeted with immunotherapy in this case, then the patients will often benefit. This is a publication from my colleague, Dr. Lee, in the original Science publication, where they looked at a bunch of different cancer subtypes that were MSI high, and included in this were 6 pancreatic cancer patients, and all 6 of the patients did have some degree of benefit. 4 out of the 6 of them had a RECIST criteria response, but all 6 of them had some degree of tumor shrinkage. We also see disproportionate benefit with the TRK inhibitors. Again, this is a pan-cancer finding. In fact, these 2 drugs that I mentioned are approved in a disease-agnostic way, but just to show that pancreatic cancer is no exception. And about 0.7% of pancreatic cancers also harbor NTRK fusions. And when you identify those NTRK fusion-positive pancreatic cancer patients, they can also have very dramatic benefit in response to their therapy. In this original publication by Dr. Drillin and the group, there was actually only 1 pancreatic cancer patient here. The rest of the arrows are GI cancer patients. But we were able to look at the use of entrectinib, another TRK inhibitor, specifically for pancreatic cancer patients. This was 2 patients with NTRK fusions and 1 patient with a ROS1 fusion. And what you can see is very dramatic, very significant, and sometimes very fast benefits to these TRK inhibitors. For example, this patient on this PET scan, this response that you see by PET scan activity was just 1 month on therapy, and the patient actually was on their way to hospice when the NTRK fusion was identified. Patient was able to start on therapy, and the performance status improved basically back to normal within just a couple of months. The subgroup of pancreatic cancers that are probably most enriched for these actionable biomarkers are those with KRAS wild-type pancreatic cancer. And several publications have taught us that probably about 5 to 10% of all pancreatic cancers do not harbor underlying KRAS constitutively active mutations. And in those 5 to 10%, many of them harbor these actionable alterations. For example, in Dr. Singhi looked at the Foundation Medicine grouping of 3,000 pancreatic cancer patients, found that about 12% of them were KRAS wild type. And out of the 47 KRAS wild-type samples, there were fusions and actionable alterations in a number of receptor tyrosine kinase and other pathway-altered therapies. And these are definitely potentially targetable. So one subgroup to look at specifically, and several of the centers around the country and around the world are actually focusing their efforts looking at fusion genes, specifically in the KRAS wild-type population of patients. And so what are some of the alterations that are seen? For example, we looked at BRAF mutations in pancreatic cancer, and from the Know Your Tumor database of over 700 patients, there were 18 BRAF mutations identified. 5 of them had the classical V600E mutations, and we did see evidence of benefit, including a sustained partial response in BRAF V600E targeted therapy for a patient treated with dabrafenib and trametinib. And actually, this work led to an ongoing trial of encorafenib specifically for BRAF V600E mutated pancreatic cancer that we would love to accrue more rapidly to. NRG1 fusions are another targetable biomarker that has been more recently identified. NRG1 stands for neuregulin 1, which is an oncogenic fusion that can, again, occur across disease types and occurs in less than 1% of pancreatic cancer. In all honesty, it's probably about 0.2%, so 2 out of every 1,000 pancreatic cancers. But when you have 60,000 pancreatic cancers a year, that number can add up. These NRG1 fusion-based tumors can respond to pan-HER inhibitors, including originally the oral therapy afatinib, and more recently to the HER2/HER3 targeted therapies such as seribantumab or zenocutuzumab. And let me show you some of the data that was presented at ASCO last year, on the left with zenocutuzumab and on the right with seribantumab. In the patients who express NRG1 fusions, even though it's rare in each of these subtypes, it's enriched in pancreatic cancer and non-small cell lung cancer. And you see with zenocutuzumab, there was a 42% response rate in the 19 patients with pancreatic cancer whose tumors harbored these NRG1 fusions. And similar outcomes were seen for seribantumab, although they only had one pancreatic cancer patient included. Another receptor tyrosine kinase that's also very targetable is our RET fusions. And this is data that was presented by Vivek Subbiah on the Blue 667 or pralsetinib study in RET fusion positive tumors. And in this trial, there were 3 pancreatic cancer patients that were included, all 3 of whom had a response to therapy. And actually, these responses lasted for well over a year, at least the last time that we discussed this with Dr. Subbiah. So this is another very actionable alteration. The holy grail for pancreatic cancer is to try and target KRAS. And again, just like in many other cancers, there is a small percentage of pancreatic cancers that will express KRAS G12C specifically. And the KRAS G12C protein is targetable because of the orientation of where that mutation occurs within the protein. And drugs like adagrasib and sotorasib can specifically target G12C mutated cancers. So Tony Saab presented at ASCO last year the group of patients with GI cancers whose tumors harbored KRAS G12C mutations and were treated with adagrasib. And what they found was a 41% response rate, and actually specifically 50% response rate in patients with pancreatic cancer, and a duration of response of 7 months. So this was promising, yet still relatively short-lived, but it opens the door to other options, including potentially combination therapies when you effectively render the tumor KRAS wild type by adding a KRAS-specific targeted therapy. And as more KRAS G12D and G12V and G12R targeted therapies come on board, this could be really promising in trying to target this patient population. But I mentioned earlier that the largest subgroup of pancreatic cancer patients with actionable alterations are those with mutations or alterations in the DNA damage response and repair pathway, the DDR pathway. And the DDR pathway is a very elegant process for our cells to be able to maintain the integrity of a normal strand of DNA. And if DNA insults occur, the single-stranded breaks can be detected through the process of ATM and ATR. The cell cycle can be slowed down to allow for DNA repair. The most faithful method of DNA repair is through homologous recombination. But if this pathway is not functional, then there is a more error-prone non-homologous end joining pathway. And each of these nodes within these DNA repair processes can be altered in pancreatic cancers. And we've seen that, again, about 17%, maybe slightly higher in sub-publications, of all pancreatic cancers harbor mutations in the DDR genes, including specifically in the homologous recombination pathway. And the canonical homologous recombination genes, such as BRCA1, BRCA2, and PALB2, really drive the response to what we see for platinums and PARP inhibitors, as we'll talk about. So we looked at, in the Know Your Tumor data set, pancreatic cancers that were treated with platinum-based therapy or not with platinum-based therapy and had underlying DDR mutations. And this was an important effort because looking at this large data set, we were able to tease out patients who had never received platinum-based therapy. And that's important because for many years, harboring a homologous recombination mutation was thought to actually confer a better prognosis. But as it turns out, it probably just is a better prognosis because we treat many of our patients with platinum-based therapy. And so many of those patients were getting platinum-based therapy and doing better as a result. But when you look at patients who receive, for example, gemcitabine nab-paclitaxel, which is a perfectly appropriate frontline therapy option, but is not platinum-based, and half of these patients never go on to get second-line therapy, then you can actually find the subgroup of patients who never receive platinum-based therapy, and we call them platinum-naive patients, versus patients who receive platinum-based therapy at any point during their pancreatic cancer lifetime. And what we found is that if the tumor harbored a DDR mutation, there was an improvement in 1 year in median overall survival when they were treated with platinum-based therapy compared to a DDR wild-type tumor. But actually, importantly, if you compare across these two graphs for the platinum-treated DDR patients versus the platinum-naive DDR patients, it actually improved median overall survival by 1.5 years, really sort of emphasizing the idea that we need to identify these patients and make sure they get at least platinum-based therapy at some point during their pancreatic cancer lifetime. Focusing specifically on BRCA1 and BRCA2 mutations, there are about 5 to 7% of all pancreatic cancers that harbor germline BRCA1 or BRCA2 mutations, and it is enriched in some subgroups of patients, such as those of Ashkenazi Jewish descent. But importantly, 40 to 50% of patients who are known to have germline BRCA1 or BRCA2 mutations do not actually have any significant family history to suggest that there's a breast cancer, pancreatic cancer, ovarian cancer familial syndrome. And this is really important because it tells us that we should never use just family history as a screening tool to decide who we should test for germline mutation. And in fact, since 2019, the NCCN guidelines and now virtually every other major institution for pancreatic cancer, such as ASCO and ESMO, have really told us that we need to be doing germline testing for 100% of pancreatic cancers, irrespective of stage, irrespective of family history, to look for those hereditary cancer syndromes. Now, for patients who have more advanced disease, this is also really important because homologous recombination deficient cells are more susceptible to another class of drugs, the PARP inhibitors. And when PARP inhibitors are used in a BRCA1 or BRCA2 mutated tumor, there is synthetic lethality, and the PARP inhibitor can force the PARP enzyme machinery to be arrested at replication forks. And if there is no ability to repair the double-stranded break that occurs, if, for example, there's homologous recombination deficiency, then that will lead to cell death. And this premise certainly has borne out in pancreatic cancer. There were some initial studies to look at PARP inhibitors in pancreatic cancer patients, including the Memorial Sloan Kettering effort, the UPenn effort, and the MD Anderson effort. And I'll highlight the Dr. Schroff's study of rucaparib in BRCA1, BRCA2 mutated pancreatic cancer, because as you see from the waterfall plot here to the right, she actually included somatic BRCA mutated tumors as well, not just germline BRCA mutated, and showed that even somatic mutated BRCA mutated tumors can respond to PARP inhibitor-based therapy. Of course, this was the background for the POLO study, which was a randomized phase 3 study looking at olaparib as maintenance therapy in germline BRCA1 or BRCA2 mutated pancreatic cancers. The primary endpoint study progression survival, which same primary endpoint that led to the approval of olaparib and niraparib and other PARP inhibitors in BRCA mutated ovarian cancer. So sticking to that primary endpoint, this was a positive study where olaparib maintenance therapy led to an improved progression-free survival compared to placebo in this subgroup of patients. Just to show that this was not drug-specific, but class-specific, Kim Rice-Binder also published her experience with maintenance rucaparib in a very similar scenario. She also did include somatic BRCA-mutated patients as well, showing that there could be some benefit there. And many of these patients had fairly significant responses to therapy and very durable responses on rucaparib, sometimes for years. In the DDR targeted pathway, there actually are also other DDR targets beyond BRCA, as well as other DDR inhibitors beyond PARP inhibitors. And this includes ATM and ATR inhibitors, preventing the cell from sensing DNA double-stranded breaks, cell cycle inhibitors that are preventing the cell from having the time to repair the DNA damage, and DNA PK inhibitors that block that non-homologous end joining pathway that the cells might use as an escape pathway to repair their DNA. There's also a body of data to suggest that DDR deficient cells are more immunogenic. Going back several years, it's been shown that BRCA1 or BRCA2 mutated tumors that are HR deficient actually depend upon that non-homologous or alternate end joining pathway for double-stranded break repair. And when that occurs, there's a higher number of mutations with large insertional deletions and overlapping regions of microhomology at breakpoint junctions that can confer a specific kind of DNA damage, different from what we see for microsatellite unstable tumors, but nevertheless a higher degree of DNA damage. And in BRCA-mutated ovarian cancers compared to DDR proficient tumors, there's actually a higher degree of neoantigen load, more tumor-infiltrating lymphocytes, and higher PD-1, PD-L1 expression. So there's reason to be hopeful that combining, for example, a PARP inhibitor in a BRCA-mutated tumor with an immune checkpoint inhibitor could actually increase the response. And that actually prompted the ongoing national randomized study of olaparib with or without pembrolizumab as maintenance therapy. So following on the POLO model, olaparib with or without pembrolizumab as maintenance therapy for germline BRCA1 or BRCA2 mutated tumors after a period of stability or response to platinum-based therapy. Our primary endpoint for this study is, again, progression-free survival. Before I move on, I'm going to talk about what are the emerging targets. Now, these are targets for which there's really not very much data at all. These are very much early in the phase 1 portions of clinical trials, but I think it's something to keep an eye out for. First is MDM2 amplification. MDM2 is amplified in about 1% of all pancreatic cancers, and again is amplified across many different disease types, probably most in certain kind of liposarcomas. MDM2 is a negative regulator of P53, and when it's overexpressed, it will inactivate P53. And so for MDM2 inhibitors to actually be active, it requires an intact P53 system within the cell. So these drugs only work when there's a wild-type P53. And there are several MDM2 inhibitors actively now in clinical trials with evidence of response to therapy in pancreatic cancer patients. None of that data that I've seen is published yet, but I just wanted to highlight one example. This waterfall plot that you see here down to the right is in dedifferentiated liposarcomas. This was presented by Mrinal Gounder last year. And dedifferentiated liposarcoma is a very aggressive, very difficult to treat cancer, not too different from pancreatic cancer. And nevertheless, these MDM2 inhibitors are showing legitimate responses in dedifferentiated liposarcomas that are MDM2 amplified. So hopefully we'll see similar outcomes for other cancers, including pancreatic cancer. The next emerging target is Claudin 18.2. I actually counted for ASCO GI. There were seven different Claudin 18.2 targeted therapies for which there were abstracts presented at ASCO GI. And so this is a really exciting target. It's primarily expressed in gastric cancer and pancreatic cancer, and high levels of expression, which is definitely a gray term, not yet fully defined, but high expression can occur in as much as 30% of pancreatic cancer. And there are clinical trials ongoing. In fact, I believe the randomized phase 2 study of gemcitabine nab-paclitaxel with or without zolbetuximab, which is a Claudin 18.2 targeted antibody, has fully accrued, and we should be seeing those results soon. But I wanted to highlight here, because it's all the data that I can show right now, of zolbetuximab, FOLFOX with or without zolbetuximab as first-line treatment for Claudin 18.2 overexpressed locally advanced and metastatic gastric or gastroesophageal cancer. This is the Spotlight trial. For me, this was the highlight of the recent ASCO GI meeting. Dr. Shattar did an amazing job presenting this data because this really represents a likely new standard of care for Claudin 18.2 overexpressed gastric cancers, because the addition of zolbetuximab led to improved progression-free and overall survival. It hasn't been approved yet, but that I would hope that it would be. And then the last novel target that I wanted to highlight is MTAP deletion. I had no idea what this was myself a couple of years ago. I had to learn about this pathway, but it's really intriguing because it follows the pattern of synthetic lethality, where loss of the MTAP enzyme leads to accumulation of MTA as well as decreased adenine, which are critical building blocks for the synthetic process of cells. And so when MAT2A or PRMT5 is inhibited in this same pathway, when there's an underlying MTAP gene deletion, this can lead to synthetic lethality and death of the cell. And there are PRMT5s and MAT2A inhibitors actively in clinical trials, multiple agents that you see listed there. And at least some of the published data would suggest that there is actual activity, including partial responses in patients with head and neck cancer and non-small cell lung cancer. And again, up to about 30% of pancreatic cancers appear to have MTAP deletion. So we're hoping that this will be an active pathway as well. So because of all this exciting emerging data, it's really incumbent upon us to be testing our patients for these different alterations. One thing we don't know for sure, definitely not in pancreatic cancer, is the overlap of all these alterations. You know, will MTAP deleted tumors overlap with Claudin 18.2 overexpressing tumors? We just don't know yet, and it's be exciting to see some of the data come out for that. But what we do know is that there seems to be an increasing number of tumors that harbor either a germline or a somatic mutation. And again, the NCCN guidelines do sort of beg us to be testing our patients who are candidates for anti-cancer therapy to look for these uncommon but actionable alterations. So let me close out with the patient scenario that I highlighted earlier. This was a patient that started first-line therapy with FOLFIRINOX, very poorly tolerated for her, but she was able to get through 8 cycles with dose adjustments. Her disease definitely did improve. She had responding disease after 8 cycles of FOLFIRINOX. And during the course of treatment, she had somatic tumor testing that revealed a pathogenic BRCA2 mutation. Because of this, she was actually able to enroll in that Kim Rice-Binder study of rucaparib that I mentioned. And this patient, who has achieved a complete response, has now been maintained in her complete response for over 5 years. So this really highlights that if we find the right patients, get them the right drugs, there can be really very disproportionate benefits to their outcomes. So when do I like to incorporate biomarker testing? Well, we know pancreatic cancer patients in general are very symptomatic when they first come to see us. And so it's very hard to wait for genetic testing before starting treatment. And as I mentioned at the very beginning, fortunately, FOLFIRINOX and gemcitabine nab-paclitaxel, while they haven't dramatically improved survivals, they have definitely made a big impact on patient quality of life and improvement of symptoms. So I will always start patients without hesitance on one of those 2 chemotherapy regimens, but then I'll get their testing started right away. And I use those test results to either try and optimize maintenance therapy, like with the POLO study, to improve second-line therapy if they have an actionable biomarker, or to be able to improve other lines of therapy, including enrolling them in clinical trials. And hopefully more and more of these patients can be living 24, 30, 36 months, and the percentage of patients can also increase. And we know, at least retrospectively, that all of this will lead to the gold standard of overall survival benefit for the whole population. This was again from the Know Your Tumor program, where we looked at over 1,000 patients with pancreatic cancer who underwent molecular profiling, and we divided them into 3 subgroups: those who had testing and had an actionable alteration and were able to get the appropriately targeted therapy. We call those the matched subgroup of patients. Those who had an actionable alteration but were not able to get access to appropriately targeted therapy, we call those the unmatched, and those who had no actionable alteration. And what you can see is that patients who were tested, that received the appropriate therapy, they lived a full 1 year longer than patients who either didn't get testing or got testing and weren't able to receive any matched therapy. So again, this really implores us to be testing our patients. So how do we make a difference? Hopefully, I've convinced you that actionable mutations are not rare in pancreatic cancer, that testing does reveal legitimately actionable alterations in at least 25%, maybe more as these new emerging targets are coming out, and that when actionable mutations are identified, appropriately targeted therapy can improve overall survival. We know that the guidelines say that 100% of patients should be germline tested, and virtually all of them should also have somatic or tumor testing. But the question is, why is this not happening? Well, first of all, because patients aren't even being treated. We were able to publish, the Canadians were able to publish, that more than 50% of pancreatic cancers from the time of diagnosis get no therapy at all, no surgery, no radiation, no chemo, nothing, which is just horrifying to think about. But second of all, patients are definitely not getting tested. The data for this is really scarce, but we think that about 30 to 50% at most of patients are getting germline tested, and probably only about 10 to 20% are getting somatic tumor testing. So to change this mindset, to change this algorithm, we really need to change the way that we do things. We need reflexive NGS and RNA testing for all pancreatic cancer patients at the point of diagnosis. If you're a pathologist, when you see a patient that's labeled likely pancreatic cancer, whether it's an endoscopic biopsy of the pancreas or a core biopsy of the liver, this really should trigger NGS RNA testing from the outset, just like ER/PR/HER2 testing is done reflexively at the point of diagnosis for all breast cancer samples. We also need to start universal germline testing. This is 100% consistent with the guidelines, and we really should put systems in place to capture blood or saliva for germline testing at the initial visit. I've really changed my practice that I carry a kit for germline testing into the room when I meet a new patient. I hand them the kit and I say, the next time you get your blood drawn, get a sample of blood drawn and we'll get this sent out right away. And we know that cascade testing can also identify patient family members, and that screening for patients, for people who harbor pathogenic mutations can actually save lives and catch these cancers early. So hopefully with these kinds of relatively simple changes, we could really be improving the percentage of patients with pancreatic cancer who are identified and who receive appropriately matched therapy. So with that, I'd be happy to take any questions.
Thank you so much, Doctor, for this wonderful presentation of yours. And it was truly interesting to learn about a lot of the positive and preclinical and early clinical strategies that we're seeing for pancreatic cancer, with it being such a huge one of the leading causes for death and very hard to diagnosis as well. So thank you so much for this wonderful presentation. I'll be passing the mic to our moderator, Rabab, for the discussion portion for today.
Thank you so much, Dr. Mike, for your wonderful presentation on biomarker-based therapies for pancreatic cancer. It was truly an amazing opportunity to learn from you. And now we move on to the next part of the event, the discussion with local leaders. We have our esteemed guest speaker, Dr. Mike Pishvaian, with us today. He's an associate professor at the Department of Oncology at Johns Hopkins University School of Medicine, and he's also an active member in the National Institutes of Health and the Alliance Pancreatic Cancer Task Force. So beginning our discussion, the first question, over to you, Madhuri.
Thank you so much, Rabab. So for my first question, Doctor, we're seeing such a immunosuppressive environment with pancreatic cancer, and with a lot of the combining therapies that go through, how can we expand further on those principles of these therapies itself and reach it out to a lot of the communities where there's a possible financial burdens as well, and how we can elaborate further on it and get better schemes?
Yeah, that's a really tough question, because we know that a large portion of the world does not have access to these targeted therapies. And in fact, I've heard numbers as much as 6 out of every 7 patients are not getting the health care that they deserve. And part of it is that these targeted therapies can be very expensive. What I would imagine is that as the global testing rates increase, the number of patients that need these therapies increase, that hopefully, and I hope this doesn't sound too capitalistic, but hopefully there's a market of scale for the companies that are developing these drugs, where when you can treat, 10,000 patients rather than 100, you could significantly lower the cost, so that, because you are treating more patients. But also, we just need efforts to make drugs more affordable. Many of these drugs, especially the targeted therapies, are small molecule inhibitors. We know that they cost pennies to make, but it also costs millions, if not hundreds of millions of dollars to research and prove their benefit. So there needs to be a balance between those two things. And I think a lot of the advocacy groups are trying to fight that balance, fight for that balance, and make these drugs more accessible to people around the world.
Thank you so much, Doctor. That was a really interesting point to hear about, and I'm hoping to see that we can achieve that balance as well in the future. Back to you, Rabab.
Moving on to the next question, over to you, Priyan.
Yes, hello. Thank you so much for that riveting presentation, and really an overview and synopsis of the biomarkers within the field. Given the landscape and the targets that you had emphasized, the next step was really therapeutics. So given the promising targets that you presented, I know that cell therapies is now an area of hot demand, and really they have pervaded many arenas of liquid tumors and now are slowly making their way to solid tumors. With that in mind, is there an area or a target that you feel down the line cell therapies would be most apt and or show most promise? And if so, what target or targets do you really feel that they could make a significant improvement in quality of care and outcomes for this vulnerable patient population? Thank you.
Yeah, thanks for that question. There's definitely some very exciting areas in this. I've been a little cynical and pessimistic about immunotherapy for pancreatic cancer. Not that there aren't really, really smart people that are trying to make it work, but it's really just the cancer that's really made it so difficult. But I'm hopeful that some of these targeted therapies may actually open the door. And the one that I'm probably the most immediately hopeful for is Claudin 18.2, if only because it's a cell surface targetable therapy, and you designing a cell therapy, a CAR T cell, for example, specific to a cell surface marker like Claudin 18.2 is a really promising avenue. And there was a study that was presented last year of a CAR T cell targeted therapy targeted towards Claudin 18.2 in gastric and pancreatic cancers. And I believe that the response rate was 50% in a very refractory gastric cancer population. Now, unfortunately, not as much in pancreatic cancers, but again, maybe there are combinations that could make those CAR T-cell therapies work for pancreatic cancer in a similarly effective way. The other target that I'll give a nod to, partly because it's my colleagues at Hopkins who are working on this, is the idea of being able to use a vaccine targeted towards the different KRAS mutations that are expressed so predominantly in pancreatic cancers. You know, more than 90% of pancreatic cancers harbor KRAS mutations, and some of the vaccine technologies that are being developed are becoming so precise and so able to activate the immune system in just the right way to elicit an immune response. I think hopefully those vaccines will be sort of the vanguard, the tip of the spear, in combination with other therapies to make immunotherapy or cell therapy, however you want to define it, towards killing those pancreatic cancer cells. So stay tuned in particular for the vaccine-based therapies.
Thank you so much.
Moving on to the next question. So, Doctor, my question to you is, how do you foresee the future of pancreatic cancer diagnostics by 2050 changing? And what therapies on the horizon do you foresee making the biggest difference to improve cancer care?
Well, I definitely come from a biased perspective, and I definitely think that the most progress has been made in the last 10 years in the area of targeted therapy. And as I've kind of walked through in this talk, I would have hoped that I could have ridden the immunotherapy bandwagon like in many other cancers, but we just haven't seen that benefit yet. And I really hope that we'll break the glass ceiling for immunotherapy. But I think in the next, I don't want to predict for the next 25 years. That's too long a window. But I hopefully think for the next 5 to 10 years that we'll really start to see molecular testing become systematic, and that the number of patients with a targetable alteration can increase beyond that 25% rate. Maybe we'll actually achieve 50, 60, 70% of patients who have something that's targetable that then can add to the armamentarium of treating those patients.
Thank you so much, Doctor, for your wonderful answer. Moving on to the next question. Over to you, Soumya.
Yes, hello, Doctor. It was a wonderful, wonderful presentation. It was so interesting to hear what you had to say. So my question for you is, what has been the biggest change or changes that you have seen in pancreatic oncology since you finished fellowship?
You know, that's a great question. I appreciate the question, because I would say the biggest change, even though I've done this whole talk about biomarker-based therapy, the biggest change has been combination chemotherapy. When I started fellowship in 2007, at my institution, there was nobody else treating pancreatic cancers routinely, and so it was kind of forced on me. And I didn't really want to take over pancreatic cancer care because it was such a difficult to treat disease. And single agent gemcitabine really only kind of slowed the decline of the patients. It didn't really reverse that curve. Once we started to get FOLFIRINOX and gemcitabine nab-paclitaxel, all of a sudden you take a patient who's tired, sick, in pain, losing their appetite, losing weight, and you're changing that course. You're taking away their pain, sometimes within just 1 or 2 treatments. You're giving them their energy back, despite the fact that they're actively on chemotherapy. You're giving them their quality of life back. Now, maybe that's only for 4 or 6 months, but sometimes it's for a year or 2. And the time that those patients have, once again, is such a blessing. I think that's been the biggest change.
Thank you so much for your answer, Doctor.
Moving on to the next question. Over to you, Harshita.
Hi, Doctor. That was a really engaging lecture. My question to you was, as you just highlighted, that precision medicine is one that everyone should have access to, but unfortunately not everyone has access to it. So what do you think are the obstacles that come in the way for patients who can't receive them? And how do you think we can overcome them?
Sometimes I feel like I'm banging my head against the wall trying to understand why it is that we're not routinely testing patients, not just with pancreatic cancer, but in many other cancer types when there's so much proven benefit. I don't know that I know the magic answer as to why people aren't being tested. I think some of it's from physicians who don't think about it. I think there's definitely in pancreatic cancer, there's a tremendous amount of cynicism, people saying, why should I bother testing? Because the chances of finding something are so low. I think that there's a cultural cynicism against pancreatic cancer. I still, to this day in 2023, occasionally hear a patient whose family member or primary care physician told them, oh, you were diagnosed with pancreatic cancer, go ahead and go home and get your affairs in order. I just think we need to just change the culture, hopefully to empower patients to really take control of their cancer diagnosis and say, okay, I need to figure out how best to treat my cancer. And if next generation sequencing and RNA testing is part of that, then that's what I need to have.
Thank you, Doctor. That was really insightful. Over to you, Rahul.
Yeah, moving on to the next question. Harshal, over to you.
Thank you, Doctor. It was a wonderful presentation. So I wanted to ask that, is there any role of personalized medicine in the context of biomarker-based therapy for pancreatic cancer?
Yeah, I think definitely yes, definitely. So personalized therapy in the sense of identifying predictive biomarkers and then putting the patients on the appropriately targeted therapy, I do think that there's definitely a major role for that. And I think there's a role for that in virtually every cancer type. So it's not just pancreatic cancer. In fact, actually, the best example of the benefit or the power of personalized medicine over the last 20 years has been in non-small cell lung cancers, where we've really seen some very, very dramatic benefits. But I think virtually every cancer subtype should be tested for these markers.
Thank you so much, Doctor. So for the next question, Shivika, over to you.
Thank you, Doctor, for such an informative keynote. So my question for you is, you spoke about cancer vaccines, and we have seen promising data from melanoma vaccines. Do you envision them making a similar impact in pancreatic cancer?
Trying to answer the question honestly. I think the answer is no, at least not yet, because it really follows the pattern of the overall immune infiltrate in these cancers. And melanomas are such immunogenic cancers that they already have a leading advantage. Using a vaccine is just another way to get the immune infiltrate activated. In pancreatic cancer, you're fighting against a very barren immune infiltrate within the tumor, coupled with a very immune suppressed microenvironment. And so you really need to take several steps. You need to get the immune cells there. You need to get them there and make them activated, and you need to take away all the suppressive signals. So I hope that eventually all cancers will be treatable with immunotherapies and vaccines the way that we see such dramatic outcomes with melanoma. But it's just, there's many more signals that need to be triggered for really immune resistant cell cancers like pancreatic cancer.
Thank you so much, Doctor. Over to you, Madhavi, for the next question.
Yeah. Thank you so much. So, Doctor, you had spoken about the CRAS protein and how it affects pancreatic cancer. And from what I understand, it's kind of essentially like an on and off switch. So, with a lot of the mutant forms that we see of this protein itself, how can we develop therapeutics that will help potentially combat not just the regular but the mutant form? And how can we avoid from overexerting on the outside environment as well for it?
Yeah, another great question, and I give credit to the biochemists and the protein chemists who've been working on this for a long time. Again, I think it's worth reading about the KRAS G12C story to understand. It takes me back to my days of molecular biochemistry and learning about alpha helices and beta pleated sheets and exactly how those proteins rotate. And there's just the right pocket when there's a G12C mutation that's actually accessible with a therapy. And it took, years of understanding protein folding and what's what I'm trying to say, sort of protein shape, to understand how to target that pocket appropriately. The newer therapies are trying to target KRAS G12D and R and V mutations in a similar way, but it doesn't create the same pocket that's quite as targetable. So there are allosteric inhibitors that are being developed, and also just downstream inhibitors like SOS inhibitors that are trying to be used as a surrogate. But I think that's still a ways from coming. There are drugs in trial right now that we certainly hope will work, but we just have to wait and see. To answer your question about how do you avoid the off-target effects, well, really, the more specific it is to that altered protein, the less likely it is to have off-target effects. But even the KRAS G12C inhibitors do have some effect on the regular KRAS proteins, which is why that some of the drugs, adagrasib and sotorasib, they don't come without side effects. They definitely do have side effects, and those are the off-target effects to some degree that just need to be either dealt with, or newer therapies that are better targeted might actually mitigate some of those side effects.
Yes, definitely, doctor. I think, honestly, when I read about the G12 itself, it was truly amazing to hear. And I hope to see we can see more miracle stories about that. And knowing that we can reduce a lot of the risks once we get very specific therapies for each mutant form or anything will actually benefit us. I think we're hoping to see a great session and trials on that as well. So thank you so much for that.
Of course.
See you later.
Thank you so much, Doctor. Over to you, Dr. Yan, for the next question.
Yes, thank you so much. So this is a question coming from, let's say, a primary care standpoint. If, let's say, one is a primary care provider and they see a patient who has a family history of pancreatic cancer, for example, what is your take on with regards to testing? Should there be testing? And if so, is there a set panel or test that these patients could and or should, in your opinion, undergo, given, let's say, strong family history of this medical condition? And if so, how early should these patients be tested? Thank you.
Sure. So you're looking at it, and I think it's a good question, from the point of view of a non-affected patient who has a strong family history. And again, fortunately, there are specific NCCN guidelines that help guide who should be tested. It's actually a long set of guidelines for hereditary breast and ovarian cancer syndromes, and pancreatic and prostate cancer fall into that. They go through the list, more than 3 family members with one of these defined syndromes, or one direct relative and one indirect relative. There are definitely very specific guidelines. Now, a primary care doctor is not reading the NCCN guidelines, for better or for worse. So I understand. And I think that's where referring them to genetic counselors can be really helpful. Fortunately, a lot of these genetic tests are also becoming very commoditized. I use a retail-based test for my patients. It's so easy. It's a simple vial of blood. And what's really helpful, because I think these testing companies got the message, many of them are incorporating genetic counseling when a mutation is identified. I definitely drink this Kool-Aid deeply, and I think we should be testing all patients for genetic alterations. I think it'll be to the benefit of all of society, at least from a cancer point of view, maybe not from a life insurance point of view. And so when these tests are done and there's a genetic counselor behind the scenes that's ready to jump in, if there's a BRCA mutation, if there's an APC mutation, if there's some other random mutation that we don't even know what to do with, that can help coach the patient and the families through that, and to sort of tell them what screening tests that need to be done. Even we don't, as oncologists, often don't know all the screening tests that need to be done for family members. And I really rely on our genetic counselors to coach, the brother or sister of an affected patient who's just been found at age 26 that they harbor a BRCA mutation. The genetic counselors help us to coach them through what they need to do. To answer your second question about pancreatic cancer screening specifically, we still don't know. The guidelines are very loose. We don't have firm data, and generally speaking, the guidelines are that patients should be tested. For patients who are known to harbor a BRCA1 or BRCA2 or PALB2 mutation should initiate screening for pancreatic cancer starting at age 50. It should be an MRI or alternating with an endoscopic ultrasound yearly. We don't know until what age, because pancreatic cancer increases with age. So should they do it until they die? We also don't know what's the youngest age that they should start. If you're 50 years old, but your sibling had pancreatic cancer at 52, should the testing actually start at age 42? So a lot of those things are yet to be fully defined.
Thank you.
Mm-hmm.
Thank you so much, Doctor. So the next question from my side is, liquid biopsies have shown promising results in lung cancer. So where are we with this technology in pancreatic cancer? Like, are there any hopes with this technology?
I wish there were. Pancreatic cancer, again, being such a stubborn cancer, won't even allow us to test the blood. So the sensitivity for circulating tumor DNA for pancreatic cancer is definitely not as high as it is for other cancers such as lung cancer. It's not zero, but it's probably somewhere between 50 and 70%. The most recent Mayo Clinic publication showed a sensitivity of about 70%. And so you're missing 20, 30% of patient tumors. And the way that was defined was because we know that 90% of pancreatic cancers harbor KRAS mutation. They looked at a large set of patients who had their blood tested for ctDNA or liquid biopsies, and only at most 70% of them had a KRAS mutation identified. So the other 20%, it has to be because the test wasn't sensitive enough to identify it. I personally do not routinely send liquid testing for patients with pancreatic cancer. I very much rely on the tumor-based testing, even to the point of repeating a biopsy if we don't have enough tissue to be tested.
Thank you so much, Doctor. Moving on to the next question, Harshita, over to you.
So my next question for you, Doctor, is how do you think AI would be in overcoming the different aspects of pancreatic cancer in patient outcome?
I think AI is a very powerful tool in pancreatic cancer and, again, in many other cancers. And I think that it really goes hand in hand with all this testing that I've been talking about, because I'm a firm believer, but I have no data to prove this. I'm a firm believer that we should be able to group pancreatic cancers based on their molecular subtypes into one of, maybe it's 10, maybe it's 100 subgroups. But if you look at KRAS, P53, SMAD4, and CDKN2A, which are the four most common mutations in pancreatic cancer, even just with those four variables, you can create quite a few subgroups, quite a few permutations of pancreatic cancer. And so if you look at those groups, and then you also combine the different therapies that we use, we may be able to actually create buckets of very specific subgroups of patients that might have specific outcomes. It might just be prognostic for this at this point, not predictive, meaning there's no therapy attached to this. But with time, if we add on additional actionable alterations, then that may also link to a therapeutic benefit.
Thank you so much, Doctor. Moving on to the next question, Harshit, over to you.
Yeah, thank you. So, Doctor, my question is, what can healthcare providers do to ensure that the patient with pancreatic cancer have access to the latest biomarker-based therapy, regardless of the geographic location or socioeconomic status?
Yeah, it's a tough question. The NGS testing that's done in these labs is actually very, very inexpensive. The actual testing of it, these DNA chips are very, very inexpensive. So it's just a matter of getting access, sometimes just physically being able to ship a sample of blood or tumor to another part of the country or another part of the world. But again, this is becoming more and more commoditized, and more countries around the world are having access to these tests. For now, I think a lot of the countries around the world are reaching out to some of the retail testing labs that are doing this testing. The testing labs aren't dumb. They're companies. They're trying to trying to increase their market for their business. So they're actually making it as easy as they can for patients and doctors around the world to have access to this testing. And I think that will almost inevitably grow. And then I think the other side of it is that as more therapies become linked to these biomarkers, then you have to do the testing. And lung cancer, with so many of the therapies that have been developed that are targeted towards specific EGFR or ROS or ALK mutations, then it gets incumbent upon the physician to test for those mutations to be able to get their patients the right therapy.
Please answer, doctor.
Moving on to the next question. Sonia, over to you.
Yes, thank you, doctor, for answering our endless questions with so much patience. So, like you mentioned in the previous question that I had asked earlier, you said that you initially didn't want to be in pancreatic oncology because there was not a lot of development at that right time. So, for today's audience, how can we better expose them to this field?
Well, I think that even if there hadn't been improvements in the treatment of pancreatic cancer, my mindset really changed for these patients. First of all, really coming to appreciate how common this disease is. Second of all, realizing how much hopelessness patients may feel when they're diagnosed with this. And our job in many ways is to help them realize that, yes, in the face of this devastating diagnosis, there is also still reason to be hopeful for improved symptoms, to not suffer, to have more time, which, the World Pancreatic Cancer Day hashtag was "It's about time." And that's very true because, every month counts for these patients. And I think the other reason to go into pancreatic cancer research specifically is because there's so much work to be done. There's so much that's not understood. There's plenty of room for any young, motivated scientist to really make a name in their field.
Thank you so much for your answer, doctor.
So as we are coming to an end, this will be our last question for today. Over to you, Shrinka.
Once again, thank you so much for your amazing answers throughout the Q&A session, doctor. So my question for you is, for our more junior attendees who are just getting into research and medicine, what inspired you to stay in the field of oncology? And how has this choice impacted your life? Has it been everything that you had initially anticipated?
I would say it's been more than I anticipated, because especially, I'm very biased, but especially in the world of GI cancers, there has been a tremendous amount of camaraderie, of support amongst our co-investigators and our co-faculty for patients, for physicians who treat pancreatic cancers and other GI cancers. And I think that a lot of it comes from the fact that we care for patients who are often very, very sick. And they need our help. And we know that many times they're going to have a bad outcome, but we want to be there for them. So I think that trying to encourage junior faculty to be in this field, it's really GI cancers are really an area where you can really make a major impact on the life of a patient and the life of a family, even if you never help fight their cancer. And I know that sounds really crazy and contradictory, but I think that just being there with them and being there for them through their cancer journey means the world to them. I'm always shocked by the number of patients and patient families who thank me, and yet I feel like I barely helped them fight their cancer. But I think they really appreciate that we took that journey with them and that we walked through that with them. So I think there's a lot of gratification that comes from being in this field, even in a disease that's very, very difficult to treat.
Thank you so much, Doctor, for your wonderful and informative keynote. We are really grateful to learn from you. The keynote and the question and answer session was really informative and interactive. Thank you, everyone, for joining us today.